Hello, welcome to my channel. I'm John Peters, and in this video, I'm going to talk a little bit about making sense of the credentials that providers have and the letters that providers have after their names when you're accessing outpatient mental health services. Okay, so in this video, I'm going to talk about why credentials matter, how to make sense of the letters after people's names in terms of accessing outpatient mental health services. And first, I'm going to talk about getting prescriptions, like a medication evaluation, and then subsequent prescriptions and refills. And then I'm going to talk about outpatient talk therapy with people who don't write scripts, but who do what we tend to think of as mental health treatment in terms of the talk therapy. Okay. And this is all about the outpatient setting. I might make a video later explaining inpatient treatment as it's kind of different, but we're going to talk about not being in the hospital, but getting some sort of evaluation and some sort of medicine or uh, therapy treatment for a mental health issue, like let's say anxiety or depression. All right. So, first, I'm going to talk about prescriptions. In the broadest sense, technically, anybody who can write a prescription can write about any prescription, right? Now, some states and federal regulations constrain providers in terms of some types of prescriptions for like pain medicine and things that have street value. But in terms of mental health prescriptions, the people who can write those typically are people with MD at the end of their name. Some medical doctors have DO at the end of their name. And they're also physician's assistants, PAs, they can write scripts, and NPs, nurse practitioners, they can write scripts, right? So, in general, any of those people who are called prescribers can prescribe, and a prescriber can generally prescribe anything, right? Now, there is a term called scope of practice, though, which is why sometimes somebody goes into their general practitioner that they see for a variety of things. Like if you have a cold and you go see a regular doctor, you go get a checkup, things like that. There are times where the GP, the general practitioner, will say, that's outside of the scope of my practice. I want to refer you to a specialist, right? So, like someone with diabetes getting referred to an endocrinologist is because the GP might say, your level of acuity and complexity is kind of outside my comfort zone of my scope of practice. So, I want you to see the specialist, right? And in general, while GP general practitioners and the general practitioner, nurse practitioners, and PAs will often be comfortable addressing more what I call garden variety anxiety and garden variety depression. Um, they will often be a good first step if your presentation is relatively uncomplicated. And I know you might not know, am I in the uncomplicated or complicated category? But what I mean by that is like if you don't have a lot of medical needs with other treatments where you would have to make an extremely careful selection of a type of medication that isn't going to like interact with other meds or other health conditions. If you need that level of expert advice, you might need the psychiatrist to be able to find something that is going to address your mental health issues, but isn't going to be problematic in the context of your wider care plan. Also, sometimes people are complicated in the sense that they have tried a med. Let's say someone's feeling depressed and they try a medication and it doesn't work. They have side effects that are problematic. That means they can't keep taking the med, or it just doesn't address therapeutically the depression. And so they want to go back and try something different, right? Some GPs at that point will still be able to say, okay, I have a plan B that we can try. But usually, if you have an initial med and then you need to kind of make a significant change of the dose, a significant change of the med, um, going to a psychiatrist is going to be better, or a psychiatric nurse practitioner. There may be psychiatric PAs out there too, but that's kind of a newer field. But basically, once you get to the point where you've had a med trial and you need something different that's also going to treat your mental health issue, my personal attitude is you'll be better served to go see a specialist, meaning the psychiatrist or the psychiatric nurse practitioner. Um, because your GP, you may be getting out of the wheelhouse of the GP at that point, right? Now, another thing to consider is that psychiatric nurse practitioners and psychiatrists, the people with MD at the end of their name, they have been few and far between for decades. So I've been in practice for 25 years. There has been a shortage of psychiatrists basically my whole career, and this continues to this day. And actually, it's kind of a worse situation today, as you might have read about in the news, because of the recent increase in utilization of care, both because of the increase of issues uh, after the onset of the pandemic, but also because of the rollout of telehealth, which meant that the barriers to access went down for a lot of people. So, a lot of people who weren't accessing services prior to telehealth getting rolled out about 5 years ago are now accessing services, which means the demand has gone way up. The provider pool has not gone way up, right? So, on the practical level, what this means for a psychiatric evaluation is that finding somebody in the community, which is often the best first choice, is going to be challenging. And you might find somebody who's taking new patients, but they say my wait list is like 4 months long, and that may not be the amount of time you want to wait to start getting treated, right? Um, the good news is you can look on the telehealth platforms for platforms that do provide psychiatric evaluations and scripts, okay? Um, that way you are much more likely to get in to see someone sooner. And so, like, for example, I'm currently working a lot on the MD Live platform. MD Live does have psychiatrists, and the last couple of people I've asked about their wait time to get in, it's just been days long instead of weeks and months long. So, seems that telehealth is quicker. But another thing to know about telehealth and mental health prescriptions is that there is a rule currently that says if you see a GP, so you see a general doctor, and it's for a telehealth visit, and it's for a new script for, let's say, an antidepressant, a GP cannot write a new script for a mental health script if it was a telehealth appointment, right? This is a weird quirk of the system right now. So if you go to your GP's regular brick and mortar office and see them, and they say, hey, I think you're depressed, here's a script for an SSRI, they can do that in their office. If they see you via telehealth, a GP can't write a new script. Now, if you see a GP for a telehealth appointment and all they have to do is write you a refill for something that somebody had written before, they can write a refill. They just can't write a new script for a psychiatric medication if they saw you for the first time via a telehealth appointment, right? So there's just a weird constraint that exists right now. Maybe that'll get straightened out at some point in the future. But that is an issue. And that's also a reason why if you go on like my platform, MD Live, which has different types of practitioners, therapists, which they call psychologists, and the GPs and the psychiatrists, you want to make sure if you're going for a mental health issue that you choose psychiatrist for the type of appointment. Because if you choose GP, they may see you and say, yeah, it sounds like you need an antidepressant, but because it was a telehealth appointment, they wouldn't be able to actually write the script for you, right? So just understand if it's a new script and it's a telehealth appointment, has to be a psychiatrist or a psychiatric nurse practitioner, right? So again, prescribers, people who have MD, DO, NP, and PA at the end of their names, right? There has been some states' legislation in some states that allow some psychologists with PhD at the end of their name to get approved as a prescriber, but that's so rare. I don't want to even include that in the mess that you're thinking about today. So just MD, DO, and NP and PA. Those are the people who are going to be able to write scripts for you. The other thing to know about the prescribers, that group, is that they're very unlikely to spend a lot of time doing anything that feels like talk therapy. And I say this because I've had patients come to me where they talk about their past care and their recent care. And part of what they complain about is the fact that they went to see, let's say, their psychiatric MP, and they had an okay conversation, but they didn't feel like it was therapy proper. And that's because they had an expectation that the prescriber was also going to be the person who did the talk therapy. Those people do exist on the planet, but they, again, are exceedingly rare, meaning you do have people out there who have practices, who are prescribers, who have a personal expertise and proclivity to do some talk therapy, but just know in general that if it's a prescriber, they're not likely to get very richly involved in a talk therapy process with you. And that's just how the system works. They are there to do a more medical psychiatric evaluation and write the script and then do the follow-up evals later as appropriate. They're just not going to spend a lot of time doing the talk therapy, which is why people often who need medications often have two providers, a prescriber and someone who is credentialed to do the talk therapy, right? Now, again, can they do it? Yes. But really that changed starting kind of actually in the 1960s and 70s. That was when it started switching over, where people who were psychiatrists who used to do a lot of talk therapy kind of stopped doing it and started only doing med management, and then other people started doing the talk therapy. So the people who do talk therapy, like providers who prescribe, are all their credentials are governed state by state. So any type of provider, doctors who prescribe and therapists who do therapy, all these licenses that people get and the credentials that allow them to legally provide a type of service, those are not federal licenses. And for many years, there have been people who want to push for uniform federal kind of standards and just one license for the whole country. Personally, I think that would be a great idea. It would make my life simpler. But right now, you have these state by state fiefdoms that just they guard their own territory. So I practice in Indiana and Washington State because I have a license in Indiana and I have a license in Washington State. I cannot legally provide services to a person who physically resides in a state where I'm not licensed, right? So that's a constraint that exists. So, and this comes to bear too on telehealth, right? So, like, I could be physically located on Mars and see somebody who's in Washington or Indiana, as long as the patient is in Washington or Indiana at the time, right? The way the rules, other than Medicare, the commercial insurance policies, and just the general rule about who can provide care to whom. With telehealth, it doesn't matter where the provider is, as long as the recipient is sitting inside a jurisdiction where you've got a credential, right? Which is why I can see people in Indiana and Washington no matter where I happen to be at the time. Now, Medicare is a different thing, although that may change in the next year or so. Medicare says that's all true, except the provider can't be outside the United States or U.S. territory, right? So for like a commercial insurance patient or private pay, I could be sitting in France, and as long as they're in my jurisdiction, I could see them. Medicare wants me to be on Guam or in the continental United States. It's just a quirk of the Medicare system at this point. But anyway, so providers who provide talk therapy, again, are going to be licensed state by state. And in general, the process to be fully licensed so that you can independently provide talk therapy, which, the law doesn't call it talk therapy. The law basically says, can you diagnose a mental health issue and can you treat a mental health issue, right? That's the language that the state laws and policies use about these types of credentials. Basically, they require you to have a master's degree in a relevant field with appropriate clinical training. And then they provide the policies require that you jump through a bunch of hoops and take tests and get supervision, do certain things to get the full credential. So the credential is not the same as the master's degree, but you need a master's degree in order to get the credential, right? So that's why you see a bunch of letters after people's names, because often you see the degree they have and then the credential or the credentials that the person has. So in order to do psychotherapy, then you basically need a master's in social work, a master's in education, as long as that program was a clinical program, an MDiv, which is a master's in divinity, as long as the program had enough clinical and the right type of clinical hours, right? or a master's in psychology, as long as it had the appropriate clinical hours, or a PhD in psychology, right? So if you have that type of master's or doctorate, then you are allowed to then pursue a credential that then makes it legal for you to provide independent services as a provider. Again, not as a prescriber, I can't write scripts, but as a provider for psychological evaluation and diagnosis and treatment for those diagnoses, right? So the credentials that people get are the ones that often have an L in them because that stands for licensed, right? So my two credentials I have, because the two states use different terms, in Indiana, I'm a licensed clinical social worker, and in Washington State, I'm a licensed independent clinical social worker, which is the same credential. They just added the word independent over in Washington, which they didn't do in Indiana, right? So I'm John Peters MSW, so I have a master's in social work, and I have these two licenses, licensed clinical social worker and licensed independent clinical social worker in the two states, right? So you often see LCSW because the person has an MSW. And as an aside, by the way, if you look at this is something that people are sometimes surprised to learn, because sometimes when I see someone for the first time and they say, well, what degree and credential you have? And I say, I have this MSW and I'm an LCSW. And they say, you're a social worker. Isn't that the welfare lady? Isn't that somebody who works for CPS? They don't do talk therapy. I want to see a real therapist, right? The reality is, in the United States, I think more than 70% of all outpatient talk therapy is delivered by someone with an LCSW, right? So social workers have the biggest slice of the therapy pie historically for actually doing outpatient talk therapy. Just as an aside, I'm not denigrating people with other master's degrees and other credentials, because people are competent if they're competent. But social workers, clinical social workers like me, we actually do diagnose and we actually do treat. Okay, we're not just the welfare lady or case managers. People with social work degrees at a lower level sometimes do that kind of work, but the clinical level is basically psychiatric work without the prescribing, right? So if someone has an L after the name, that's the licensing credential that they have. And you might see LCSW, like I mentioned. You might see licensed mental health counselor, LMHC, which that's most likely associated with a person with a PhD or a master's in psychology. And then you have LMFT, licensed marriage and family therapist. And so all those L credentials are the licensed credential that allows the person to do outpatient evaluation, diagnosis, and treatment of mental health issues. Now, one thing to say about PhDs is that there are many clinical psychologists with a PhD in psychology who get the license, the LMHC, to do therapy. But one type of service that they do that isn't done by people like me or the MDs is certain types of evaluation. So people who get the PhD in clinical psychology are more often experts in standardized evaluations and standardized tests than the rest of us. And so if someone needs a formal evaluation for a learning disability, if someone needs a formal evaluation for ADHD sometimes, although the other providers can do it technically, if someone needs a formal evaluation of just mental health capacity, and they are, especially if they're going to use standardized tests like the MMPI, the Minnesota Multiphasic Inventory, and things like that, clinical psychologists are the practitioners that have the most expertise for standardized evaluations, even though technically MDs can do it, technically people like me can do it. But if an MD or someone like me is going to do it, we can really only do it with a significant amount of focused, specialized training for the particular type of evaluation that we might be participating in. And we just don't tend to do that. The PhDs in clinical psychology, that's a lot of what they train for and end up working with, right? So if they say, hey, I need you to go get a learning disability evaluation, you're likely to end up talking with someone with a PhD in clinical psychology who's going to be the most competent person to do that kind of evaluation. So I hope I cleared up some common misunderstandings that exist with the letters that come after people's names who work in the field of outpatient mental health, and that's helpful for you. As a practical matter, too, um, we have to have these licenses not only to practice, but also to be able to sign off on the forms that allow you to get reimbursement when insurance is a component of how a service is getting paid for. So that's an issue too. And I'd also say that another issue that I just want to throw out there is over the last many years, the services of people who call themselves coaches is quite popular, and you don't have to have any sort of certification or licensure to call yourself a coach. Like anybody can wake up this morning and say, "Guess what, everybody? I'm a coach." And so there's no legal control over the coaching field. But I'll throw this out there, be a self-aware, informed consumer, and just know that if you're seeing someone who's not credentialed, they don't have degrees, they don't have licenses, um, if you get into the field, the domain that I tend to work in, which is diagnosis and treatment of mental health issues, you may be out of the wheelhouse of the coach, right? And so, A, you may not be getting well served, and B, a coach shouldn't be operating in a scope of practice that's beyond their training and licensure, but people do, which is why I throw it out there as something just to be aware of, right? But one thing is, as a practitioner, I'm always happy for people to ask questions about my credentials, about my background, my training. I'm okay with people questioning my sanity and my logic if they want. But if you see somebody and you have any confusion about, what the domain and scope of their role is in your case and what they can provide you and can't provide you, just ask, because none of us should get offended at those kinds of questions, because you should be clear who you're seeing, what they can provide, what they can't provide. And if we're not the right provider, then you should, get support to find the person who actually can help you, right? But one place to start in that whole mess is often your general practitioner. Although, as I said earlier, that person might decide that you're complicated enough that you need additional expertise, either with a psychiatrist for a better med-eval, and they might also decide you need a talk therapist, which they're not going to do, right? They sometimes can provide decent, competent referrals for that type of thing, so that's often not a bad place to start. And the other thing is you can look at listings. If you're looking for outpatient talk therapy, you can look at listings. For example, Psychology Today is one of the biggest listings where people who have private practices often will put their own practices, and you can put in your zip code and look for a type of provider. That's one of the easiest ways to see who's practicing in your area. Although not everybody lists themselves there, it's not comprehensive, but that's sometimes better even than calling your insurance or getting the list from your insurance about the providers. Because I'll be honest, when I've talked to insurance companies about their list of providers, most of them tell me that they only update that list every 6 months to 12 months. So that means, like, if I get paneled on an insurance, I might be in network for you, but I'm not even on their list for 6 to 12 months. So if you need somebody and you look, there's probably more people actually in network for an insurance company than they even are broadcasting via their standard list for that. So that's kind of an issue. But it related to that, if you see someone, let's say someone sees me, and they want to know if the particular person, so like, is John on my insurance, and will the insurance reimburse? The best way to ask that question to the insurance company is to contact the provider and say, I want to know your NPI, your National Provider Indicator, and that National Provider ID which is called NPI. It's a long number, and that's the one that is most accurate. So if you use other information like name and address and stuff, sometimes you call the insurance company, waste a couple hours of your time going through their crazy menu systems and whatnot, and then they can't even give you a good answer. But if you get the NPI of a provider and then you call the insurance company, they should have an accurate database to be able to look up that number and say, okay, yes, we will reimburse for that person, or no, that person's out of network, or blah, 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 stuff like that. The last thing I'm going to say before I end this video, just in terms of these various broad issues of how to utilize outpatient mental health services, is that unfortunately, if you have a Medicaid or one of the forms of Medicaid that exists under the ADA and the state insurance plans, Medicaid unfortunately does tend to limit who you can see, partly because both Medicaid and Medicare make providers jump through some extra hoops in order to be a provider for either one of those. So, for example, I'm not a Medicaid provider, I am a Medicare provider. So if someone with Medicaid came to see me, they may be covered. I can't bill their insurance because I'm not a Medicaid provider. And that means that they would have to pay me out of pocket, which might be prohibitively expensive for some folks. So if you have Medicaid, some form of Medicaid, calling the customer service number on the back of your Medicaid card, talking to a case manager via Medicaid is one way to find out who in your area takes Medicaid. The other would be to call whatever your nearest community mental health centers and ask them that question, because they usually know the answer to that as well, because they're typically Medicaid providers. So doctors' offices, private practices like mine may not be, but the larger community mental health centers, 99% of those places are Medicaid providers and can give answers to that question about the local Medicaid providers. All right, so I hope this was helpful for you. If you found it helpful, feel very free to hit the like button below. If you like the channel in general, feel free to subscribe, and I will see you in another video.